First, I want to thank the organizing committee and the Budi for inviting me to this wonderful meeting. May I have my slide on? Okay, thank you. I will talk about the DORV with pulmonary stenosis and how to biomechanical structure. I just want to share some of the case and my personal opinion. And the DORV could be classified into the 4 clinical classifications, including DORV-PS type. It means the patient do not have secondary pulmonary stenosis. And the DORV follow type is either subaortic or double combined VSD with pulmonary stenosis. And the surgical structure is relatively similar to follow, and either by primary repair or stage repair. And how to preserve the pulmonary valve is a good point of discussion. And the DORV-TJ type is the subpulmonary VSD. It could be with or without pulmonary stenosis, but without pulmonary stenosis, we generally prefer the arterial switch and the intraventricular rerouting. And for the secondary pulmonary stenosis, we consider either Rasteli or Nikaido procedure. And in the DORV with remote VSD, it is a very controversial issue about how to choose single ventricle or biventricular repair, especially with the patient with pulmonary stenosis. And I will show some experience. Recently, a publication from Korea group about the DORV, the so-called 50% rule of a subacute VSD. It clearly demonstrated using the CT to define the degree of overriding and the relationship with the trachea valve and the mitral valve. Okay. So in this case, we can where is the point? Well, is the data point? I'm not sure. Okay. And so this is a demonstration of the overriding of aorta to most of the way from the right ventricle. But for this case, this is a relative borderline case. We can find the pulmonary artery is about 50% on the right ventricle and 50% on the left ventricle. So it could be argued about this is a DORV TGA type, or this is a TGA with anterior monoline VSD. So some controversy about the terminology. And the first I talk about the DORV is follow type. Generally, the principle is like tetradic follow. In my institute, we either do a primary repair or stage repair. If the pulmonary artery size is good and the patient's weight is enough, we go do a primary biventricular repair. And if the patient is very low body weight and the pulmonary artery size is relatively small, we generally prefer the shunt as a primary palliation strategy. And in certain cases, if the VSD is relatively small or restrictive, we will consider do a VSD enlargement. Which one? And this case shows the conduction and the duration of enlarge the VSD during the repair. Like for this case, this is aorta is likely almost from right ventricle, and the aorta and the mitral are discontinued. And the VSD after, if we do not enlarge, the VSD probably very relatively small to the aorta, and so in this case we do a VSD enlargement, and then intraventricular rerouting, and in certain cases, the infantile is very relatively narrow, so we think we could not do complete pulmonary valve preservation, so we need to do a transcatheter repair to relieve the pulmonary stenosis. And if the patient have pulmonary atresia, it's more difficult to define. It is a follow type or pulmonary VSD or it's a DORV, but in this case, you can see the pulmonary artery from the right ventricle. The root is from right ventricle instead of the usually tetradic follow, extreme tetradic follow. So in this case, we can see the pulmonary artery is very, very small and located in posterior to the aorta. but the distal pulmonary artery seems acceptable size. But if we need to do a biventricular repair, we need a very long steady conduit to the right ventricle. So in this case, we do a bilateral BD shunt and followed by steady. So the patient, we do a shunt right side and the left side, and to palliate the patient till the patient is about 4 years old, which at that time is about 10 kilo. And then we can see this is the pulmonary artery over here, and the aorta is quite anterior to the VSD. And so this is the CT shot after several shunt operation. The central PA remains very small, but the distal pulmonary artery vascular bed is acceptable. So in this case, we do a extended central pulmonary artery reconstruction followed by a steady and the intraventricular rerouting for this patient. Yeah, so we can see the left ventricle outflow and right ventricle outflow was quite well, and we don't have the contigua or homocoagulation. So if the patient requires pulmonary valve, we either hand-made Gold's valve or use a tissue valve for the pulmonary outflow tract. This case is quite unusual. We can see the pulmonary artery is located very right side from the aorta. So it is definitely double aortic right ventricle, but the aorta relationship may be like a so-called anatomically malposition. And the VSD probably subaortic, but maybe also some degree of remote. So, but in this case, we do a BD shunt first, and then followed by a transannular patch over here and the intraventricular rerouting. The patient is quite well for 10 years without re-intervention. And if the patient goes the pulmonary atresia and also the remote VSD, it is very controversial because the non-commit and the remote, there is even more remote than remote. So this case is like in the middle of the remote. So it is located in maybe probably mid of the septum. So this case we can still do a biventricular repair, but in early years, this is more than 10 years ago in our hospital, another surgeon, I think he want to do a biventricular repair, but upon opening the right ventricle outflow, he found it's a remote VSD. So at that time, it was only 6 months, so he abandoned the intraventricular rerouting and do a biventricular shunt as a palliation. However, after 4 years, the PH becomes desaturated, so the gradient is patent, but the PSI is okay. But the patient grow up, so in this case, we converted to a biventricular repair instead of the TCPC. So we take down the gradient and reconnect to the pulmonary artery and do an intraventricular rerouting and do a pulmonary artery and do a modified Rasteli. We do a transannular patch and put down a pulmonary valve to restore the biventricular repair. And this case is a very remote VSD with pulmonary atresia. We can appreciate the VSD, the upper margin is below the medial pulmonary muscle, and the lower margin is just on the diaphragm side. So it takes a very long intraventricular tunnel repair from the diaphragm side to the aorta. And in this kind of case, we should consider the possibility of obstructing the tricuspid valve and also the right ventricular outflow tract. So in this case, we have maybe so-called multiple patch technique to reroute the intraventricular tunnel. And there are some reports about using the Gold's graph or somewhat to reroute it. And we need the state for finish the biventricular repair. And in the patient with the TGA type VSD with pulmonary stenosis, we can see this pulmonary stenosis over here, and the aorta is anteriorly. And in this kind of case, the principle is similar to the TGA VSD PS. We heard Dr. Kim and many lectures today and yesterday. Generally, we prefer a Rasteli procedure if the pulmonary stenosis is moderate. If it is a very small pulmonary annulus, we probably just go on the steady instead of complex Nikaido procedure. But if there's a so-called medium size of pulmonary stenosis, we prefer to do a Nikaido procedure to smooth the left ventricular outflow tract. Generally, we do it at not newborn, but maybe several months to several years old. This is another complex case with DORV-TJ type pulmonary stenosis and superior inferior ventricle. And this case, we think about very long years, 3 and 4 years, to think about it. Could we do a biventricular repair for this patient? And finally, we do a CD and try to make some simulation about the outflow tract. And then we found that it is impossible to reduce the VC directly to the aorta without obstructing the trachea valve and the pulmonary outflow inflow. So we also found that if we do a Nikaido procedure, it is technically possible. So we do the Nikaido procedure. And in this case, I usually take on both coronary artery instead of the coronary artery in situ technique. So the coronary bottom are taken out, and then take out the aortic valve. And after taking out the aortic valve, we cut open through the pulmonary valve. This is the pulmonary valve we transected. And cut into the ventricular septum. Yeah, and then this is the trachea valve pulmonary muscle, and then we can do the VSC repair. This case, I use a interrupt plate proline suture and a Dagong page to make the new left ventricular outflow tract. And then we implant the neo-aortic valve back into the left LVOT. And the coronary transfer was just by the case by case. So this case we implant it and then require a page augmentation for release the tension between the coronary artery and the button. And so this is the coronary button, and this is the neo-aortic valve. And for the right ventricular outflow tract, I only use a page to reconnect the right ventricular outflow to the pulmonary artery with the core maneuver. This is the pulmonary artery for future of the right ventricular outflow tract. And so the patient is doing well after biventricular repair. And this case is a DORV with remote VSD and also the pulmonary artery stenosis, which was more prominent in the subpulmonary area. So this is the aorta. This is the pulmonary artery. Is somewhat a little bit anterior posteriorly, and the single coronary artery from posterior side, and the VSC is located in the non-committed position, relatively far away from both coronary artery. Initially, the left ventricle is relative hypoplasia, so we cannot decide to go on single ventricle by ventricle. And after discuss with TCPC or compress, and finally we decide to make a 3D printed out model to simulate the operation. And so this is a printed model, so we can practice on the model, and then we figure out we need to do a subcoronal resection or subpulmonary resection for the pulmonary stenosis, and the page should be relatively quite curved to reconnect the VSD to the aorta, and relatively long. So in the operation, we use the multiple page technique to use the curved graft and the two segments to connect to the VSD to the neo aorta. And this patient also have the stenosis of the right lower bronchus. So before the cardiac surgery, we do the bronchioplasty first to restore the bronchus first, and then after the bronchus stabilize, we go on biventricular repair. And this is the final outcome. And for this particular case, we do a RBOT incision to to approach the VSC and the subpermanent stenosis. So there is a page to finish out RBOT, and the patient was doing well after surgery. So in summary, the biventricular repair for DORV-PS requires tailored approach to individual anatomy. And if the patient is very complex, I think 3D, either SR or printed out is quite important to surgical planning. Thank you.